Okay, good evening, everyone, and thank you for joining us at this hour. I welcome to you all to this insightful webinar on childhood obesity, organized by Strand Life Sciences in collaboration with Regency Hospital. We are honored to have you all here as we discuss critical aspects of childhood obesity and how we can work together to combat this growing health concern. I am Soumya and I'll be the host for today's session. We have two esteemed speakers who will shed light on the role of pharmacotherapy and genetic testing in childhood obesity. Now let's begin. Our first speaker today is Dr. Veronica Arora, consultant clinical geneticist from Sir Gangaram Hospital, New Delhi. She is Secretary Delhi Chapter ISOPAB. She is head North Zone Ispat Society. She is treasurer Delhi SFM and many more to her experience. Welcome, ma'am. Next, we have Dr. Neha Agrawal, a renowned pediatric and adolescent endocrinologist from Regency Hospital, Lucknow. Ma'am has done her fellowship in diabetes, Royal Liverpool Academy, Liverpool, UK. She has more than 20 nationals and international publications. She has co authored chapters in IAP textbook of pediatric endocrinology. Welcome to the session, ma'am. Now,
Thank
I would
you.
request to call up Dr. Veronica Arora. She will enlighten us on how genetic testing can help in diagnosing and managing childhood obesity effectively. Dear ma'am, I would request you to please take the session forward. Uh, Dr. Arora.
Ma'am, are we audible to you?
Should I start?
Yes, ma'am.
Okay. Good evening, everyone. It's my honor to talk on childhood obesity on the World Obesity Day today. Thank you, Dr. Neha, for organizing this lovely program about obesity, where we talk about childhood obesity, the factors that influence it, the genetic factors, and then move on to treatment. Strand Diagnostic has always supported all the academic ventures, and we're really thankful to them. Moving on, it said that childhood obesity issue is critically important because it is important to health and success of our kids and of the nation as well. So this what was said by Michelle Obama, and it echoes throughout the globe. If we have a number of people that we take together, the obesity is dependent not only on the environment and the food we eat, but on the genetic makeup. It is a multifactorial disorder, though there is some obesity which is purely genetic. Most of it is affected by the genetic makeup that is made up of single nucleotide polymorphisms, meaning mutations on the nucleotides that we have. Also, there are epigenetic patterns that are influencing the genetic makeup themselves. Epigenetics is part of our existence of genetics that influences our living or patterns of the chromosomes without changes in the DNA sequence itself. Then finally, we have the gene environment interactions. Now, these gene environment interactions cannot be positively predicted by us, and thus these multifactorial disorders do remain an enigma. Why do some people say that I eat less and become fat, and some people may eat a lot and don't? So, there are all these influences that really make up our genetic, environmental, as well as obesity circle. What is the use of knowing that there is a genetic, epigenetic, and environmental influence. The use really is, of course, in the treatment and how we can modify the same. So, for example, in high intensity interval training, known as a HIIT, low protein nutrition medication can work for some. Endurance training, a low carbohydrate nutrition can work for some, as well as a bariatric surgery or a reduced portion size can work for others. So, today we will go ahead and talk about more of this and understand that there is a model that explains where there is an interplay between environmental genetic factors and epigenetic changes in establishments of obesity. Genes, environment, and epigenetic marks can directly lead to increased adiposity. Genes and environment can interact through their influence on the epigenome. Although epigenetic changes may cause obesity, it is often not really clear if they precede obesity or obesity causes these kind of changes. So there is also always a balance between what environment gives us and what we give back to the environment. The energy intake and the energy expenditure needs to be in a balance, what is known as calorie deficit. And this calorie deficit cannot be the same for all individual and is again predicted by genetic as well as epigenetic influence. So the aim is in genetic testing is not to have just names of multiple syndromes or label the children as syndromic, but to help understand the etiology of the disorder, give them some precision medicine related treatment if possible, and finally to prevent recurrences. So, obesity is defined by the WHO as an abnormal or excessive accumulation of body fat sufficient to cause adverse health effects. The pandemic has shifted from malnutrition to obesity, so we have to deal with one of them either ways. In 2013, the prevalence of overweight and obesity in developed country was 23.8% for boys and 22.6% for girls, and just the half of it in developing countries. Among the overweight children, almost half of them live in Asia. Obese children have more than 50% probability of carrying their obesity into adulthood, while non obese children have a 10% ability of the same. Furthermore, childhood obesity is a risk factor for development of different comorbidities as well, including type 2 diabetes, dyslipidemia, hypertension, and obstructive sleep apnea. The percentage of obesity that can be attributed to genetic obesity, pure genetic, could be from 6% to 85%. So, obviously, this doesn't make sense. So, how can something range from a 6% to 85%? So, if I give you a median of 15% childhood obesity overall and maybe a 25% childhood obesity, could be purely genetic, but overall obesity is a multifactorial disorder. Adoption studies show a strong relationship between the BMI of biological parents and their adopted children. However, no similarity was found with adoptive parents. So, why do we need to understand obesity and what all influences it has on our body? So, whatever system you think of, there is a negative impact of obesity on the same. And the psychosocial quotient is one of the major system that is influenced by it, and for me one of the most important. There is a poor self-esteem, depression, eating disorders. There could be a pseudomotor cerebri, cardiovascular system. We are all aware of the dyslipidemia, hypertension, coagulopathy. Endocrine, again, a very important system influence. Obese individuals are much more susceptible to get type 2 diabetes, precocious puberty. GI disorders like gallstones, steatohepatitis, and of course cirrhosis, which is not mentioned here as well. Musculoskeletal system we cannot ignore because they seem that they could be treatable there, but they call major morbidity in these patients. So when we talk about obesity, there are three major kinds. That is the syndromic obesity, the non-syndromic obesity, and the multifactorial obesity. In syndromic obesity, we have some genes, approximately 30 genes, which are known to cause single gene disorders, which will recur, which we can prevent. Then we have some genes which is non-syndromic, which will only cause obesity and no other syndromic features like intellectual disability. And the common obesity is the one that is the multifactorial one we see from families with obesity. Many genes involved, around 35 genes, but each will have a small contribution to the disease. So, three major types: monogenic, syndromic, and polygenic. So, genetic obesity syndromes, when we talk about testing, we suggest genetic testing in patients with extreme early onset obesity. That is the one which starts before 5 years of age and that have clinical features of genetic obesity syndrome, in particular extreme hyperphagia and or family history of extreme obesity. So we have an answer of where we should offer testing. So we offer testing when there is an obesity before 5 years of age or when there is a genetic obesity syndrome. Then we have a Mendelian or monogenic form of non-syndromic obesity when there is only obesity and no other features. Over the last 15 to 20 years, it has been characterized that single gene mutation can cause severe early onset obesity, and these genes encode enzymes and receptors that have a physiological role in development of the hypothalamus and the leptin melanocortin pathway. So we all know about the leptin melanocortic pathway. So this pathway is activated when the leptin that is produced in the adipocytes crosses the blood-brain barrier, which we can see here, and binds to its receptors, localized in two different groups of nucleus, that is the neuropeptide Y and pro-opiomelanocortin nucleus of the thalamus. One of these groups expresses the neuropeptide and other the pro-opiomelanocortin, and the cart which inhibits food consumption, that is the anoxygenic pathway. When the blood has food restriction or is fasting and there is decreased energy, the stomach secretes ghrelin that binds to the ghrelin receptor, which is localized in the orexigenic pathway, increasing the production of neuropeptide Y and agouti related peptide. So as we can see that there are two hormones here. Ghrelin causes a positive effect on the neuropeptide Y and leptin causes a positive effect on the pro-opiomelanocortin. So they work in an antagonistic fashion to each other. The orexigenic neurons project into the paraventricular nucleus of the hypothalamus as is shown here, and their neuropeptide acts as antagonistic of the melanocortin pathway. So here we can see that if there is deficiency of leptin, it causes obesity, and if there is excess of the orexogenic compounds, that is the ghrelin, that also will cause obesity. The genes that have been mentioned here have now been implicated to cause obesity, and they have a definite role in causation and are caused by mutations in both the copy of the genes. These are the autosomal recessive disorders. One of them here, caused by the PCSK1, it has also been implicated in an autosomal dominant manner. That means only one copy of the gene needs to be mutated for the same. So we have the leptin gene, the leptin receptor gene, the proprotein convertase gene, that is the PCSK1, the POMC gene, and some other genes which also have been implicated. So let's talk about the two common genes, that is the leptin genes. So the leptin recessive form of obesity due to functional mutations in the LEP pathway are rare and mostly identified in family with high levels of consanguinity. Of course, that's not necessarily always present, but a high level of leptin can result in this. To date, less than 40 individuals have been found to be homozygous for each of the mutations. So now we come on to the leptin receptor genes. Severe hyperphagia and early onset extreme obesity has been related to the leptin receptor genes. The pro-opiomelanocortin gene something that you can remember is by this is that there is an alpha melanocyte stimulating hormone that also becomes excess, and these patients and children have red hair and pale skin. So if we have this, then we think of the POMC mutations or variants. Second, we come on to the Prader-Willi syndrome. Prader-Willi syndrome is the most common cause of syndromic obesity in children. The incidence is around 1 in 1000 to 1 in 3000. The clinching features of diagnosis are neonatal hypotonia, feeding difficulties, childhood obesity, excessive hunger, hyperphagia. They will have an almond-shaped eyes, straight ulnar border of the hands, and certain stereotypies. So they're also obsessive compulsive. Growth hormone is a great treatment for these children. They become taller and their weight also decreases. So there are some consensus criteria, some of which I already mentioned. So the clinching diagnosis is a fat child who had history of failure to thrive when the child was a neonate. So it is caused by deletion in this particular region of 15th chromosome, that is the 15q11.2 deletion. So diagnosis of Prader-Willi is done by a test known as MSMLPA, that is methylation specific MLPA. We do not perform a chromosomal or a monogenic test for the same. So when there is obesity with intellectual disability, what else do we think of? We think of Angelman syndrome. They will have high BMI. They will also have a happy demeanor with seizures and microcephaly. The test of choice again being the MSMLPA. Fragile X syndrome, this is the most common cause of intellectual disability, which is inherited in boys. They will have large head, large ears, intellectual disability, and obesity later. Test of choice again is an MLPA. And so, Prader-Willi, Angelman, and Fragile X, you can order an MLPA. Then there are deletions and duplications, which can also cause deletions of the genes that cause obesity, and the deletions of chromosome number 6, a Q1P and 22Q have been known to cause the same. So, of course, you don't need to remember all this, but need to remember that the common disorders like Prader-Willi, Angelman, Fragile X, their phenotype we keep in mind, so that we can go ahead and test for them, as these tests are not commonly included in the next generation sequencing in the CMA panels. Then we have some syndromic causes including Alstom, Albright hereditary osteodystrophy, Bardet-Biddle syndrome, Carpenter, Rubinstein-Tabby, and Schaff-Young. This is the list for students who want to remember some of the syndromic causes. They're very common and they should be kept in mind. Next, we have 1p36 deletion syndrome. 1p36 deletion syndrome is caused by deletion of the um chromosome number 1, the distal part of chromosome number 1. The clinching feature is the straight eyebrows, the microcephaly, and obesity later. So, if we are suspecting the syndromic diagnosis, we can perform a chromosomal microarray as well. So, let us just come on to a case. So in this family, they presented to us, there is a 2 months old male child who was brought for evaluation of dilated cardiomyopathy. So that was their primary concern, and second born of a 7th degree consanguinity. So as we can see that there is no, at present, just one complaint of cardiomyopathy. When you have a genetic case, it is extremely important to go ahead and have a pedigree analysis and draw a multi-generation pedigree. So these are two children here. One of them had hypokalemic paralysis, another had dilated cardiomyopathy, and there was consanguinity. The two lines show consanguinity. No other affection. Antenatal period, mother had gestational diabetes and PIH, born by term by LSCS, birth weight of 4.1 kg. Perinatal period was uneventful. Previous first male child of the couple had cardiomegaly and died at 2 months of age. So similar presentation suggestive of a genetic disorder and autosomal recessive disorder. When the examination was performed, the weight was on the higher centile, not really fitting into obesity still. And the muscle tone was a little bit raised, serum CPK was normal, acyl carnitines were normal, 2D echoes did show cardiomyopathy. Now, isolated cardiomyopathy has no associated feature was present except the overweight. So, genetic etiology in the form of an autosomal recessive disorder was thought because there was a recurrence and the parents were not affected. So, next generation sequencing based multi-panel testing was ordered and a cardiomyopathy genes was advised. And we found an Alstom syndrome, which is a primary syndrome of obesity with cardiac and eye involvement. It is a ciliopathy involving the cilia throughout the body. So, once the diagnosis of this Alstom syndrome was made, then we went ahead and checked again, and the weight was actually at at greater than 19 centile at 4.5 months of age. So this is an obesity syndrome here where there was an additional finding of a cardiac disorder. So in syndromic cases, a lot of times where there is intellectual disability or cardiac involvement, the obesity takes a backseat. But we need to identify these disorders to so as to give a diagnostic advantage to the family. So, Alstom et al. First described the clinical features of this syndrome in 1959. There is obesity, short stature, a chondrodystrophy dystrophy of the eye, progressive sensorineural hearing impairment, dilated or restricted cardiomyopathy, as well as endocrinological abnormalities. It is a likely underdiagnosed disorders. Feature may not be present in infancy or early childhood, or they really do evolve with age. Overlapping phenotypes among many ciliopathies, absence of many features in some cases, so it is not always thought to be syndromic. So there is a genotype phenotype correlation. That means that if we get variants or mutations in one of the exons of ALS1 gene, and there is an onset of retinal generation which is much earlier, really helps us geneticists in counseling the patients. If there are variants in exon 8, then there is hardly or any renal disease. There are no allelic disorders, so the only disorder called by Alstom known today is the Alstom syndrome by this gene. Exon 8, 10 or 16 are the hotspot. That is, most of the variants that we find will be in these mutations. So, before I end my talk, I would just like to highlight upon the genetic testing options and how will you take an approach or proceed with it. So, the first thing, of course, is to rule out the Prader-Willi syndrome because it is the most common cause of genetic obesity in children. You look for hypotonia, failure to thrive in the infancy and in the neonatal period, followed by childhood obesity. A thorough clinical examination and a pedigree analysis is very important, and to look for syndromic features. Syndromic features do give us a clue of doing genetic testing. They just make us sure that we must perform it. A panel or exome based testing, that is the next generation sequencing, is extremely important once if you have ruled out the Prader-Willi syndrome and the Angelman syndrome. So go ahead, do a Prader-Willi syndrome testing, and then you come on to a panel or whole exome sequencing for obesity. There is a symptomatic management of obstructive sleep apnea in Prader-Willi with growth hormones, new drugs, family counseling, and reproductive counseling. And finally, we have some very exciting medicines and drugs coming up for Prader-Willi syndrome, as well as other pharmacotherapy in obesity. And I'd like to call Dr. Neha Agarwal, who will explain to us about the pharmacotherapy and give us exciting news about what's new in obesity. Thank you so much.
Ma'am, there are only two questions, Abhi. Do you want to take it?
Yes, yes.
One question is by Dr. Amruta. She's asking, does genetic testing can be offered to obese pregnant women?
Yes, of course, it can be offered, though the chance of finding a variant would be lesser, around you can say 5 to 7% chance of finding something. And but it will just like any other adult who is suffering from obesity.
Okay, ma'am. The next question is, this is anonymous. Can exome be done for obesity?
Yes, absolutely. We do a Prader-Willi test first, and if that's normal, we go ahead and do exome sequencing.
Ma'am, Prader-Willi MS MLP है.
Yes, yes.